One of the lectures in our series of Men as Patients is bacterial prostatitis. Bacterial prostatitis can happen because of poor drainage of secretions from the peripheral ducts of the prostate gland, reflux of urine into the prostate tissue, and commonly follows urinary tract infections. Some common risk factors for prostatitis are urinary tract instrumentation, urethral strictures, and urethritis, most commonly due to STIs. There are some common pathogens that we should be thinking about when a patient presents with bacterial prostatitis. The most common by far is a gram-negative bacilli, E. coli. That causes anywhere from 50% to 80% of the cases. And other Enterobacteriaceae, such as Klebsiella and Proteus, account for about 10 to 30% of cases. Some other pathogens you may see would be Enterococcus, Pseudomonas species, or atypical species such as chlamydia or trichomonas. And then it can sometimes be caused by staphylococcus and streptococcus species, but the virulence of these strands is somewhat debatable. Knowing these common pathogens is important when determining empiric therapy for bacterial prostatitis. So first we'll start off by talking about acute bacterial prostatitis, or ABP. It accounts for less than 1% of prostatitis cases. It's most common after transrectal prostate biopsy or genitourinary instrumentation. Patients would present with abrupt voiding symptoms, pain, and they may present with systemic signs of infection like fever or body aches. Some complications of ABP are progression to chronic bacterial prostatitis, or CBP, and then patients can also end up with prostatic abscesses. This slide just shows a few different tests that providers may use in the diagnosis of ABP. The first is a digital prostate palpitation. This can be uncomfortable for patients with prostatitis because of the pain and inflammation associated with the prostate gland, and there is some risk of possibly introducing a new infection. This must be done gently in these patients. And some findings that you would find from a digital prostate palpitation would be a prostate gland that's tender, swollen, and warm. You may also find that a urinalysis may show nitrates or leukocytes, and this has a 95% positive predictive value and a 70% negative predictive value. You may opt to get urine cultures in order to determine the pathogen, and then you can consider blood cultures and complete blood cell counts. Chronic bacterial prostatitis, or CBP, can present a little differently. This accounts for 5 to 10% of prostatitis cases. It may be a complication of ABP, or it may not be. The way that these patients would present would be a prolonged urogenital symptoms, and this would be for 3 or longer months. Your patients may also be presenting with relapsing UTIs, and this is really the hallmark symptom, even though it's only present in less than 50% of patients. But you would see UTIs recurring in these patients with the same organism each time. Organism characteristics in chronic bacterial prostatitis are bacterial biofilm formation, prostatic calculi, and more. These bugs can be more treatment resistant. Some tests you may see done to diagnose chronic bacterial prostatitis, again, a digital prostate palpitation. Same type of issues with this as in the ABP, but prostate gland findings, you may find that the prostate gland is tender, that it's softening, that there's firm induration, and you may find nodularity as well. There's also a test called the 2-glass test, and this is essentially 2 different urinalysis tests. So the process is that you collect the first urine sample midstream, um, and you would expect the culture to be negative in this setting because this first urine sample represents urine from the bladder. You would then do a prostatic massage and then collect a second urine sample. And the second urine sample represents the prostate gland. So in this sample, you would expect positive cultures and leukocytosis, showing signs and symptoms of infection with a specific pathogen. There are a few different considerations that we have to think about when it comes to treating prostatitis. The first is that the prostate tissue can be difficult to penetrate. When it's inflamed, it can have a little bit better penetration, but as the inflammation goes down, that's when the antibiotics have a harder time penetrating into the tissue. We also must consider the pathogen that we're trying to fight, and then again, the tissue penetration of the specific antibiotic. As you'll see in the next two slides, that the therapy of choice tends to be fluoroquinolones. Some things that we would worry about fluoroquinolones would be side effects, especially in our elderly patients, and then resistance as well. Treatment of acute bacterial prostatitis is a little bit different than treatment of chronic. The first thing we want to evaluate is whether the patient's showing systemic signs of infection, and if that's the case, they may need to be admitted for IV therapy. In this situation, we prefer broad spectrum beta-lactams, such as piperacillin tazobactam or Zofran, cefotaxime, or ceftazidime. You could also use an aminoglycoside as an adjunct if warranted. If the patient is clinically stable and not showing systemic signs of infection, then you can start with oral therapy. Ideally, we'd start with a fluoroquinolone, such as levofloxacin or ciprofloxacin. You could also opt for trimethoprim sulfamethoxazole or Bactrim double strength, and that's one double strength tablet orally twice daily. Generally, these infections are treated for 6 weeks. When it comes to chronic bacterial prostatitis, in this situation, we definitely want to get urine cultures in order to guide therapy. You may or may not decide to hold off on treatment until you get your cultures back and you know exactly the pathogen that you're treating against. In general, first-line therapy, again, is a fluoroquinolone, ciprofloxacin 500 milligrams twice daily, or levofloxacin 500 milligrams daily. You could also opt for a second-line option if the patient can't tolerate fluoroquinolones, and that would be a doxycycline 100 milligrams twice daily, azithromycin 500 milligrams daily, or clarithromycin 500 milligrams twice daily. For chronic bacterial prostatitis, the typical duration is usually 4 to 6 weeks, but depending on if patients are able to clear their infection after 6 weeks, you may see patients who require up to 12 weeks of antibiotics.